Hello everyone, welcome to Test and Explanation of Super Specialty Pediatrics Part 5. Here I am going to take up the questions that were discussed with you that you must have solved related to pediatric neurology and pediatric endocrinology. Traditionally speaking, neurology and endocrinology are not among the strongest, but here I am trying to stick to the topics which are being frequently asked in super specialty exams, both NEET SS and INI SS, plus I will be taking up some of the borderline topics which have been asked in the recent exams. First of all, as is the norm, what are the topics which need focus for super specialty exam in these two areas? In neurology, you need to be thorough with neurocutaneous syndrome. Any average super specialty exam has 2 questions. Yes, you heard it right. It is not a single question. At least 2 questions are asked from this topic. So neurocutaneous syndrome, very high yielding. Summary, rapid revision part, I have already discussed, and detailed video already available. So only relevant points I will be discussing today. Febrile seizure is important. Anti-epileptic drugs are important, both the older ones as well as the new ones. Autoimmune encephalitis, last 2 NEET SS exams, there were 2 consecutive questions. If we follow the trend, who knows, maybe the third time also you may get a question. So Neurocysticercosis, pyogenic meningitis, Guillain-Barré syndrome, cerebral palsy again a high yielding area, about 2 to 3 questions are being asked in the recent exams. Spinal muscular atrophy and DMD, including the updates on therapy. Please go through Nelson updates. They are very important. And finally, congenital myopathy. Congenital myopathy traditionally has not been asked. It was traditionally a topic of INI SS exam, but in recent exams, some questions occasionally you will find in NEET SS as well. Coming to endocrinology, in endocrinology, you have growth hormone deficiency, which is one of the favorite of AIMS as well as the National Board of Examination. So whether you sit in INI SS or you sit in NEET SS, you will always get a question on growth hormone deficiency related topic. Then disorders of sexual development is important. Men and APS syndromes are important. Congenital hypothyroidism, diabetic ketoacidosis, diabetic monitoring. I will be discussing briefly about the table. Then Turner and Klinefelter syndrome are important, and CAH continues to be evergreen topic in the exam. With this in mind, let us start with the discussion. The time I spend on a topic will be related to its importance. Many of you have requested, sir, if you can just point out what are the relevant parts in Nelson that we should go through. That also, where needed, I will be summarizing. So let us start with the question number 1. It's an easy one, and this is actually a recall question. It was asked in NEET Super Specialty 2022. The image might have been different, but a similar image was asked. So question number 1 says, a child with epileptic spasms is found to have the below mentioned skin lesion. What is the diagnosis and treatment? You can see this child is having multiple hypopigmented lesions, and there is presence of infantile spasm. These are the lesions what you call as ash leaf macules. So these lesions are what appear to be ash leaf macules. They are hypopigmented lesions typically found on the trunk of a child. And because epileptic spasms are present, the likely diagnosis in the patient is tuberous sclerosis. So what is the diagnosis in the patient? It is tuberous sclerosis. And in tuberous sclerosis, for infantile spasm or epileptic spasm, vigabatrin is more efficacious compared to ACTH. And so your answer to this question is B, tuberous sclerosis and vigabatrin. So B is your correct answer. Let us do a quick review of the topic of tuberous sclerosis. Now, tuberous sclerosis, genetic basis of tuberous sclerosis was asked in the mid-year exam of INI Super Specialty. For those targeting INI SS, you can remember that genetic basis is a previous year question. The exact recall is not there, but at least the topic is there. So, according to Nelson, there are 2 genes which are involved in producing tuberous sclerosis. One of them is TSC1 gene, which codes for hamartin. TSC2 gene codes for tuberin. TSC1 gene is present on long arm of chromosome 9, whereas TSC2 gene is present on short arm of chromosome 16. TSC2 tends to produce more severe disease. However, the disease can occur due to either of the 2. Now, how does tuberous sclerosis genes, how do these proteins, their mutation causes problem? Where these 2 genes are considered tumor suppressor gene. So the products, that is hamartin and tuberin, are involved in suppressing a tumor pathway. So if there is absence of either one of them, the pathway will go out of hand and it will produce benign tumors. And many of them can turn into malignant tumors as well. This is the basis of tuberous sclerosis. So TSC1 and TSC2, what they are? They are tumor suppressor genes. This is very important. They are tumor suppressor genes. The question asked in NEET SS, there were statements related to something being tumor suppressor, something acting on the pathway. This kind of question was asked, as was told to me by the students. So TSC1 and TSC2, they are tumor suppressor genes. And loss of either TSC1 or TSC2 causes overexpression of a pathway known as mTOR pathway. mTOR pathway becomes dysregulated, which is responsible for producing the manifestation of tuberous sclerosis. And the hallmark in these patients is CNS involvement. Although the disease is a neurocutaneous syndrome, means there will be CNS involvement, there will be skin involvement, but out of them, which is the hallmark? It is CNS involvement, which is the hallmark. So what about the CNS involvement? The neurological involvement shows the characteristic brain lesion known as cortical tubers. An important point about cortical tubers: tuber means like a potato. Cortical means in the cerebral cortex. So they are benign tumors, small in size but can be fleshy if you look at autopsy, and can appear even before birth. So they can appear even in the intrauterine life. Apart from that, there are benign lesions which show calcification called as subependymal nodules. They occur in the subependymal region. Some of the subependymal nodules can turn into locally aggressive tumors called as SEGAs. What is the percentage? 5 to 10% of them turn into subependymal giant cell astrocytomas. These astrocytomas do not show malignant transformation, but they have a propensity to encroach upon the CSF space and they can cause obstructive hydrocephalus. Treatment of SEGAs is surgery. Surgery needs to be done. If you can remove it, great. Otherwise, at least a VP shunt needs to be inserted. And for surgically not amenable tumors, you can go for mTOR inhibitors. It's very important. You can get a fresh question on this. There are 2 mTOR inhibitors which are approved for use in such patients. You can use either sirolimus or you can use everolimus. So sirolimus or everolimus will be useful with or without surgery, particularly in surgically non-resectable tumor. These are the agents that you will be using. And most common clinical feature is epilepsy, followed by intellectual disability, and autism spectrum disorders are also common in tuberous sclerosis. The type of epilepsy is infantile spasms, also called as epileptic spasms, but they may or may not be associated with hypsarrhythmia. This is an important point. The tuberous sclerosis epileptic spasm may or may not be associated with hypsarrhythmia. And what is the treatment in such patients for infantile spasm? That obviously you will be going for vigabatrin. So vigabatrin will be preferred. Second line drug in these patients will be ACTH. And remember, ACTH is always given in high doses. There is no role of low dose ACTH in such patients. Even everolimus and sirolimus have been tried in a few refractory patients. What is TAND? Details of TAND I have discussed in my rapid revision videos. What I am discussing here is relevant to the topic or the points which are related to recent NEET SS and NEET SS exam. So basically, I'm trying to explain the topic also. I'm trying to do a brief review as well so that you can utilize this resource for a quick, rapid revision of your notes as well. So TAND stands for tuberous sclerosis associated neuropsychiatric disorders. It includes intellectual disability, autism spectrum disorder, ADHD, anxiety, and depression. TAND is a part of tuberous sclerosis spectrum. What about the skin involvement? You can see the skin involvement here. The skin involvement can be in the form of ash leaf macules, which are seen in 90% patients. These are hypopigmented lesion. Facial angiofibromas occur on face. They begin between 4 to 6 years. They are not present at birth and they tend to increase. If they are less numerous, they may be mistaken for acne. The more numerous ones will resemble benign tumors. Shagreen patch is a raised, rough, crusty area found in the midline on the lumbosacral region. And then forehead fibrous plaques can be present. Periungual fibromas around the nail beds can be seen in the patient. What are the other organs which are involved? 50% will have cardiac rhabdomyomas, 75 to 80% will have renal angiomyolipomas. But remember, these renal benign tumors are not common in the first 5 to 7 years. They appear beyond 10 years of age. And retinal hematomas may also occur. Some of them may show mulberry-like appearance. So these are the features of tuberous sclerosis. It's a benign, recurrent tumor-producing syndrome. Because it involves CNS and skin, we call it as neurocutaneous syndrome. I hope the brief review is going to be useful, and the points I have mentioned taken from Nelson, but those are the points which over the years in various super specialty fellowship exams and INI exams, they have been asked. I have tried to cover them at one place. End of the day, you are supposed to go through the detailed video also. Let us have a look. If you get a clinical picture, a spectrum of picture, how would you make the diagnosis? You can see these are the ash leaf macule. This is the shagreen patch in the lumbosacral region in the back. You can see there is a periungual fibroma, and these are the tumor-like lesions occurring on the face. So this is, if they give a panel like this, the likely diagnosis in the patient is likely to be tuberous sclerosis. Moving to question number 2. A young child's MRI brain revealed multicystic encephalomalacia as depicted in the image. Which among the following shall be the likely clinical correlate? Now look at this MRI finding. There is multiple cyst formation and severe brain damage. This is a child where the quality of life is going to be very poor. And the key word here, multicystic encephalomalacia, is the typical MRI finding associated with patients of spastic quadriplegia. It's the MRI finding of spastic quadriplegia. Catch hold of the keywords. There is a table given in Nelson. This table is very useful for rapid revision close to the exam. So look at this table. So we have the major types of cerebral palsies are mentioned. Spastic diplegia is the most common variety in the Western world. So this is the common variety in Western world. Spastic quadriplegia is only 20% in America, but it is the most common in India. So if they ask which is the most common worldwide or in Western world, answer will be diplegia. But if they say most common cerebral palsy in India, the answer will be quadriplegia. It is not a good thing because quadriplegia is very severe. Spastic diplegia is typically associated with periventricular leukomalacia. Some of them may have periventricular hemorrhagic lesions as well. Whereas spastic quadriplegia may be associated with periventricular leukomalacia, but the characteristic lesion is multicystic encephalomalacia in these patients. So the multicystic encephalomalacia goes in favor of spastic quadriplegia. Diplegia is more common in premature children, whereas quadriplegia tends to occur in relatively term babies who develop asphyxial damage. Then hemiplegia can occur in utero stroke. It is a part of thrombophilias. And extrapyramidal, dyskinetic or choriothetoid cerebral palsy is a feature of kernicterus. It can also occur in hypoxia and mitochondria. And hypoxia typically involves globus pallidus, putamen, and thalamus. These are the areas. So parts of basal ganglia are typically involved. For those who asked me, sir, what are the important tables from Nelson? This is an important table. And I promised many of you on social media who messaged me, sir, if you could take up a few tables or tell us the important tables. End of the day, entire Nelson is important. And it would be a futile exercise trying to read every table of Nelson. But if there is one table which is very important and could be, a fresh MCQ, this is one of those tables, right? Go through the table. But if you don't have access to the new Nelson or you are too lazy, at least go through this table, which I am showing in the screen. Moving to question number 3. Now, this is similar to NEET SS 2023. This is actually a recall question of NEET SS 23. Holoprosencephaly is associated with which of the following pathway defects? There are 4 pathway defects. It is the sonic hedgehog signaling pathway, that is SHH pathway, which is associated with non-syndromic type of holoprosencephaly. Remember, holoprosencephaly, if they ask you whether it is syndromic or non-syndromic, syndromic form is typically associated with Patau syndrome, trisomy 13. But if they say non-syndromic form, it will be genetic mutations in the SHH pathway. So answer to this question, it's a one-liner, sonic hedgehog signaling. It is also written as SHH pathway. Now, let us do a quick review of the topic of holoprosencephaly. Holoprosencephaly is a defective prosencephalic cleavage, that is incomplete cleavage of the cerebral hemispheres. So there is a fetal structure known as prosencephalon. Initially, prosencephalon is a single closed globular structure. Then a cleft forms in between. This divides the single ventricle into 2 lateral ventricles. It divides the 2 cerebral hemispheres into 2 parts. And there is development of corpus callosum, which is joining the 2. Now imagine this cleft formation in the prosencephalon does not happen. What will happen? There will not be 2 cerebral cortical hemisphere. There might be 1 hemisphere. There might be incomplete separation or non-separation of the 2 ventricles leading to a single ventricle. And there might be absent corpus callosum. And these may be associated with other facial defects also. This condition, the failure of separation of the 2 cerebral hemisphere, is called as holoprosencephaly. The technical things you can always read. I am trying to simplify. Prosencephalon, there is a cleft which forms, which separates the two cerebral hemisphere. If this split does not happen, that condition is called as holoprosencephaly. You can see in the photograph also. Now, there are three types of holoprosencephaly, the classical types. The most severe form is A-lobar, no cleft forms. You can see that there is no cerebral hemisphere formation, severe microcephaly occurs, absent corpus callosum and single ventricle instead of two lateral ventricle. It is generally not compatible with life and can be seen in patients of Patau syndrome. Then we have semi-lobar, where the posterior segment separation happens, but the anterior part does not happen. This is the front, this is the back. So posterior part, it is happening, anterior part, it is not happening. And third one is the lobar, where the cleft will form, but the anterior 1/3 part may not be separated from each other. So it will typically involve the frontal lobe, particularly the posterior part of frontal lobe. So these are the three varieties. Lobar can be compatible with life. All the three will have intellectual disability. A-lobar generally not compatible with life, and semi-lobar generally also does not have a good outcome. So what are the three types? The A-lobar form is the most severe form. Semi-lobar is intermediate, and lobar is the third form. And there is a fourth variant known as syntelencephaly, where segmental non-separation occurs in posterior frontal and parietal lobe. So posterior part of frontal with parietal, that is called as syntelencephaly. So these are the four types. Actually, classically speaking, these are the three ones. This is called as the variant form. Now, most patients will have associated neurological abnormalities and facial dysmorphism. The typical facial dysmorphism you will see in the patient, sometimes there can be a single eye instead of separation of the two eyes, or the gap between the two eyes can be less. So some patients can go on to develop hypothyroidism. There can be palatal defects. And the severe form, the not compatible form, may have cyclops appearance also. Apart from that, these children can have a single nostril, so the midline structures of the face may not be able to separate symmetrically as it happens in you and me, right? So details obviously are given in Nelson. I'm trying to simplify and give you a brief summary. Now, holoprosencephaly can be syndromic or non-syndromic. 60% will have chromosomal abnormalities, and single most common cause, I told you, it is a potential MCQ point. It is trisomy 13. What is trisomy 13? By this time, you already know it is Patau syndrome. Can it occur in Edwards syndrome? Rarely it can occur in Edwards syndrome also. In fact, there are many syndromes where it can occur. Other syndromes include Charge syndrome, the CHD7 gene mutation, Pallister-Hall syndrome, Rubinstein-Tyaby, and Smith-Lemli-Opitz syndrome. And non-syndromic will have genetic polymorphisms or mutations in the sonic hedgehog, that is SHH signaling pathway defects. And better than diabetes is also considered a risk factor. So this is also an important risk factor. Outcome in the patient is generally poor. It depends upon the severity and complications. Holoprosencephaly is important. Everyone has a tendency to read only schizencephaly or porencephaly or lissencephaly. But holoprosencephaly sometimes goes under the radar, and Nelson does give some time talking about holoprosencephaly. And this is something examiner knows. So all these, congenital malformations of the brain, NEET SS, they are a probable topic. TnE SS, particularly neurology part, they are very important for your exams. So, question number 4. Let's go to the question number 4. Extreme delta brush pattern of EEG is mostly seen in which of the following condition? Now, it's a one-liner question. It is typically seen in autoimmune encephalitis, where there are antibodies forming against N-methyl D-aspartate, that is NMDA receptor. So, it's a one-liner, that extreme delta brush pattern. It is TnE SS 23 question. It is seen in anti-NMDA-R autoimmune encephalitis. What exactly is extreme delta brush? Extreme delta brush basically means that there are baseline delta waves, and on delta waves, there is superimposed rhythmic beta activity. So just like there is a brush, how does a brush look like? In a brush, you have, this is the stalk of the brush, and then you have this appearance like this, right? This is how a brush looks like. So similarly, you have waves happening upon waves. That is called as extreme delta brush pattern. So this is how the extreme delta brush looks like. So on a delta wave, there will be, this is the zoomed in version. You can see this serrated version of beta activity happening on the underlying delta activity. That is called as extreme brush pattern. It has a high risk of developing seizures and prolonged illness, but at the same time, by itself, it does not indicate seizure activity. So what exactly is extreme delta brush? You can write on the side that there is a baseline delta activity, delta waves with a frequency of 1 to 3 hertz. It gets superimposed on top of delta waves. There is superimposed fast rhythmic beta waves which have a frequency of 20 to 30 hertz. 20 to 30 hertz. This type of pattern is typically seen in patients with anti-NMDA receptor autoimmune encephalitis. Question number 5. A female child aged 1.5 years. There will be some easy questions or, just telling what is the answer and what is not the answer, or 2 or 3 points. So there are areas where I will spend more time. The reason will be either it is an atypical thing, or I want to emphasize a certain thing, or maybe the points I'm discussing, they are actual questions in the other exams also, as I had. That was whole rationale. If you have gone through the previous videos, the way I'm discussing is I'm trying to cover in the explanation some of the previous year questions also, for which a proper recall is not there. So question number 5, a female child aged 1.5 year presents with microcephaly, regression of milestone and abnormal hand movement. Now, ideally, it should not be a 1.5 year because the diagnosis is very clear. It's a Rett syndrome, right? There are stereotypical hand wringing movement, microcephaly, and regression of milestone. Regression of milestone typically occurs between 6 to 12 months. But this is a child presenting at 1.5 and they have not mentioned. So many times there will be a late presentation in an Indian setting also. So this is a patient with Rett syndrome. So what are the points in favor? Female child. It occurs, Rett syndrome is having MECP2 gene mutations. Males are stillborn. They die in utero because MECP2 gene mutation in a male fetus, it is not compatible with life. Females come into this world, first 6 months, there is a relatively normal development. There may be slight developmental delay, which may not be picked up. Later on, there is onset of neuroregression, hand-wringing movements, ataxia, and cardiac illness may also occur along with the neurological problem. The only good thing about this disease, about Rett syndrome, the new drug is available. Drug of choice in these patients is trofinetide. Brief review of this I have already done in my videos. Question number 6. Now this is NEET SS 2023 PYQ. A child diagnosed with SMA is planned to be given nusinersen. Nusinersen is a molecular gene therapy. What shall be the route of administration of this drug? Again, table of Nelson. This is summarizing the 3 types of SMA therapies which are FDA approved. Nusinersen, also called as commercially known as Spinraza, it is approved for use in all ages. It is given intrathecally. This is the loading dose. Then second is onasamnogene abeparvovec, ZOI, which is also known as Zolgensma. It is approved for use in the first 2 years of age and it is given intravenously. The only good thing about it is single time dose. And third is risdiplam, where the child is aged 2 months or above and it is given orally. So oral, this is IT, intrathecal, this is IV, and this is oral. These are the key points you should remember for future exams. So answer to this question is C. Also, details of SMA treatment. There is a proper video in Nelson update that I have discussed. That video contains simplification of what is told in Nelson, and there are some additional points, additional photographs also which have been mentioned because it is a very high yielding topic. If you are a Prep Ladder SS subscriber, I would recommend last week before the exam, please go through that video. It's a very important video. Now question number 7. A 6-week-old neonate with poor feeding, fever, seizures and depressed sensorium was suspected to have meningitis and started on cefotaxime and amikacin, which is the rational thing to do. His CSF culture was positive for Listeria monocytogenes. What next needs to be done? Now, it's a very important thing that what they have done so far is absolutely fine. Starting the patient on combination of beta-lactam with aminoglycoside for sepsis coverage, and because they were suspecting meningitis, so 3rd generation cephalosporin was added. The only catch here is the culture has grown Listeria. Listeria is unique that it is inherently having partial to moderate to complete resistance to cefotaxime. Listeria, the drug of choice is always ampicillin. Giving ampicillin with any aminoglycoside like gentamicin or amikacin is adequate coverage for Listeria. In fact, earlier we used to use cotrimoxazole, but in young children we generally avoid using trimethoprim sulfamethoxazole. So ampicillin should replace cefotaxime in these patients. You can go through chapters of Nelson as well as the major protocols. And if you are working in ICU, this is a scenario which is often asked in the rounds as well. I still remember Dr. Probeen, who was the head of neonatology department. Sir used to ask, like once upon a time, sir did ask this question to me. Of course, I did not know the answer at that time. But answers you don't know tend to stick. Later on, you search for them and later on they stick in your mind. And this is not just a Viva thing. It is also important from your super specialty exam point of view. NEET SS? Yes, but INI SS? Similar question can be asked. It's a practical problem where you have to change the therapy while dealing with newborn ICU. The only difference is it was a newborn, not a 6-week child when I had seen that patient. So ampicillin, you will replace cefotaxime with ampicillin in such patients. Question number 8. Similar to NEET SS 2023, which of the following is the most frequently seen lesion in neurofibromatosis 1? Now, this is NEET SS 23. It was a very easy question actually. Spinal tumor, meningiomas and bilateral vestibular schwannomas are not part of neurofibromatosis 1. These tend to occur, particularly B and D tend to occur in neurofibromatosis 2. The answer to this question is C, optic nerve glioma. This is the most common brain tumor. It is benign, but most common brain tumor seen in NF1. It is actually seen in only 10 to 15% cases. But among these lesions, this is the only lesion which is seen in NF1 frequently. Now, one-liners on NF1, which have been asked in the previous years. What is the single most common lesion? It is Café au lait macules. They are non-specific but seen in 95 to 100% of all patients. But if they ask most specific or pathognomic lesion, the answer will be axillary or inguinal freckling. And according to the latest criteria of neurofibromatosis 1 diagnostic criteria, one out of these should be bilateral in nature to be considered as a criteria. I hope you have gone through the updated criteria for NF1. Internet is full of older criteria. Updated criteria I have already discussed in updates as well as in the rapid revision part. Then most common CNS tumor in NF1, I just told you, it is optic nerve glioma. And the most common neurological complication is dyslexia or learning disability. That depends upon the reference that you are using. Some of the review articles don't say dyslexia or learning disability. They write cognitive dysfunction. Now, which one to choose? Examiner is a pediatrician with more experience than probably my or your age. So he or she would know that all of them are mentioned and they are all related to the same thing only, right? So they will not ask you to pick. Based upon the references, these are the words which are mentioned. And DD of NF1 with spread 1 gene mutation, there can be a lesion, there can be a syndrome known as Legius syndrome. Legius syndrome patients tend to have macrocephaly along with cutaneous manifestation, but other manifestations are generally absent. So these are the important one-liners on NF1 from exam perspective. Now, question number 9. For a child diagnosed with ADHD, which of the following SNRI? What is SNRI? Selective norepinephrine reuptake inhibitor. These are SNRIs. There are 2 SNRIs which are approved for use in ADHD. One of them is atomoxetine and second one is viloxazine. So it's a one-liner question taken directly from Nelson. Remember that guanfacine is a alpha agonist. It is approved for use, but it is not a SNRI. Methylphenidate is a stimulant. It is one of the first-line agents, but not an SNRI. It is a stimulant medication. Duloxetine is an SNRI, but it is not approved for use in ADHD. So duloxetine, venlafaxine, they are not approved for use in ADHD. So what does Nelson say? Nelson says clearly that there are 2, according to US FDA, there are 2 agents which are approved for use. One is atomoxetine and second is viloxazine. They take for up to 4 weeks to be effective and they have common side effects. This important side effect is decreased appetite, so weight loss can occur, and they have increased chances of suicidal thinking and behavior, particularly in older children or adolescents. So you need to watch out for decreased appetite, nausea, and suicidal thinking in such patients. Question number 10. A child with refractory epilepsy was planned to be started on ketogenic diet. Which among the following is or are indications to use this anti-epileptic therapy if uncontrolled on first and second line drugs? Now, on ketogenic diet, I have already discussed in my videos as well as updates of Nelson. And ketogenic diet will be useful in Rett syndrome. It will be useful in Dravet syndrome. It will be useful in refractory epilepsy, basically infantile spasm. Rolandic epilepsy is also called as benign childhood epilepsy with centrotemporal spikes. And this is an epilepsy with good outcome. Typically occurs in mid-childhood and tends to improve as the age increases. More common in boys, and in Rolandic epilepsy, there is good control when you use carbamazepine or oxcarbazepine. And that is why it is not an indication to use. So what is the correct answer? 1, 2 and 4 is your correct answer. Now, what does Nelson tell you? Nelson says that the ketogenic diet is considered effective in glucose transporter 1, that is GLUT1 deficiency, pyruvate dehydrogenase deficiency, myoclonic static epilepsy, tuberous sclerosis, Rett syndrome, Dravet syndrome, infantile spasm, and severe myoclonic epilepsy of infancy. It is also useful in selected mitochondrial disorders, glucogenesis type 5, Landau-Kleffner syndrome, Lafora body disease, and SSPE. Right? So what is basically ketogenic diet? You are giving a high fat, low carbohydrate and low to moderate protein diet to the patient. That is ketogenic diet. The mechanisms of ketogenic diet is too complex to be discussed in a small discussion video like this. It is discussed in the detailed video on the app. Please go through it. I have tried to summarize the best I can. Question number 11. All of the following are the components of Levine criteria for cerebral palsy except. Now, Levine criteria has been given for cerebral palsy. Levine criteria says that there are 6 criteria and they can be remembered by the mnemonic POSTER. What does POSTER stand for? P stands for posturing. So if there is posturing, especially abnormal extensor response, that indicates one of the criteria for cerebral palsy. Second is O. O stands for oropharyngeal problems. Grimacing, swallowing difficulty, dysphagia, any thrust, any lip smacking movement, any oropharyngeal problems which are abnormal. S stands for strabismus. It can involve one eye, it can involve both the eyes. T stands for tone abnormalities. Tone abnormally low or abnormally high. Both of them are considered to be part of the Levine's criteria. E stands for evolutionary responses. Evolutionary response. What is the meaning of evolutionary response? In bracket you can write evolutionary. Evolutionary, what happens is the primitive reflexes tend to disappear, but in these patients, the primitive reflexes will persist. Primitive reflexes will persist. That is called as evolutionary response. E, and R stands for reflexes. Which reflexes are we talking? Not primitive reflexes. We are talking about deep tendon reflexes. The deep tendon reflexes will be brisk or exaggerated, and the Babinski sign will be positive in these patients. According to these Levine's criteria, it is said that any patient having 4 or more out of 6 criteria, it is diagnostic of cerebral palsy. So it's an important criteria you are supposed to add. Now, if you look at the options, which is not a component of Levine's criteria, seizures are not a. Question number 12. Chiari II malformation is a common association of which of the following? Now, it's a one-liner. Chiari II malformation is typically associated with meningomyelocele, and that is the answer. In fact, almost 80 to 90% association with meningomyelocele is seen in these patients. Now, it's a very often asked topic, posterior fossa malformation. An examiner will ask you to differentiate and pick a side between Chiari II malformation, previously called as Arnold-Chiari, and Dandy-Walker malformation. Important thing, Chiari II malformation, the posterior fossa size is small, whereas Dandy-Walker, the posterior fossa is large and cystic. So this is a cystic malformation of posterior fossa. In Chiari II, because the posterior fossa is small, so what will happen? Where would the cerebellum and brainstem go? They will herniate into the cervical spinal canal. Whereas in Dandy-Walker, cerebellum itself is underdeveloped. Particularly, the vermis part is hypoplastic. And fourth ventricle is dilated into a large cyst within the posterior fossa. What about fourth ventricle? Here it will be compressed. Here it will be cystically dilated. Associated condition, it is strongly associated with with myelocele or meningomyelocele. It is associated with meningocele alone, the association is less prominent. Meningomyelocele, the association is strongly prominent. It is strongly associated with agenesis of corpus callosum or structural problems in the other organ systems. Hydrocephalus occurs here also. Hydrocephalus occurs here also. But here in Chiari II, hydrocephalus predominantly involves the forebrain and lateral ventricle. Here it involves the hindbrain or fourth ventricle. Apart from that, the photographs we have already discussed. Please go through this table. It's a very useful table. Distinguishing. Question comes like this. All of the following are suggestive of Arnold Chiari except, or Chiari II except. All of the following are seen in Dandy-Walker except. Which of the following can be used to distinguish Dandy-Walker from Chiari II? Or they will show you a photograph along with some case scenario or hydrocephalus, and they will ask you to make the diagnosis. The photograph will be of MRI or CT finding, and you have to look and tell the diagnosis. So please go through the topic in detail. It's a very important, useful table you can add to your notes. Question number 13. It's a NEET SS 2022 MCQ. A child aged 12 years is having features suggesting recent onset, proximal muscle weakness, positive Gower sign, CPK within normal limits, poly-mini microclonus is present. Now, proximal muscle weakness means it is unlikely to be myotonic dystrophy. Becker's dystrophy again does not present like this and does not have poly-mini microclonus. Plus the CPK will be slightly elevated in such patients. Now we are left with A versus D, and many of the students got confused, but the clinching point here, two things. First of all, Nemelin rod congenital myopathy is not that common as we tend to think of, number one. Number two, SMA type 3 will be having fasciculations, and these fasciculations along with weakness will produce a typical phenomena called as poly-mini microclonus. This is the clinching clue, and so the answer to this question is A. Even if this poly-mini microclonus was not mentioned, I would still be answering A as the answer only based upon the epidemiology, because when they talk about Nemelin rod congenital myopathy, some of them can have late presentation, but age 12 year and now having recent onset muscle weakness goes more in favor of SMA type 3. SMA type 3 is also known as, other name of this is Kugelberg-Villander disease. The age of onset is generally after 18 months of age, and some of them can come to attention, particularly in a resource-limited country like India, in the late childhood or adolescent period also. Nemelin rod congenital myopathy. Now, these patients, whenever you have to talk, there will be no poly-mini myoclonus, and that option is ruled out in such patients. And Nemelin rod myopathy will have no tremors. It will have no tremors. There is a variety, except known as Amish variety of congenital myopathy, that is Nemelin rod congenital myopathy, but Amish variety will always manifest in the infancy. Its onset is in infancy. This is a child with onset in 12 years. So again, presence of tremors, poly-mini microclonus goes in favor of SMA type 3. Now, Nelson also talks about it, and Nelson clearly says that the presence of muscle weakness proximally along with fasciculations produces poly-mini microclonus in the limbs in such patients. Question number 14. A 10-year-old female child is evaluated for unstable gait, easily falling, and has been progressive, and she also has high foot arches. Now, this is high foot arch. This foot arch which you can see, this is called as pes cavus. So, pes cavus, unstable gait, easily falling, everything fitting into a diagnosis of, what is the diagnosis we are thinking of? It is fitting into a diagnosis of Charcot-Marie-Tooth disease type 1A, also known as peroneal muscular atrophy. Also known as peroneal muscular atrophy. This is the diagnosis. And in such patients, the typical sural nerve biopsy finding is interstitial hypertrophic neuropathy. Remember that these patients have atrophy of the anterior compartment of the legs and thigh. Remember that CMT1A, the typical stalk-like appearance of bilateral lower limb is seen, but here they are not using that word. What does Nelson say? Nelson says muscles of the anterior compartment of the lower legs become wasted, and the legs have a characteristic stalk-like contour. Stalk is a bird. And the muscular atrophy is accompanied by weakness of dorsiflexion, and eventually foot drop happens. And apart from that, pes cavus deformities can also occur in the patient. Proximal muscle weakness is a late manifestation and is usually mild. Axial muscles are not involved. Now, the important thing about this topic is diagnosis of CMT1A. And what does Nelson say? It is a INI SS topic which has been asked in the exam. First of all, you should know that whenever you do nerve conduction velocity, they will be reduced as low as up to 20% of the normal. And it will involve both motor as well as sensory nerves. Serum CPK or serum CK level in these patients will be normal. But what is the investigation of choice as well as gold standard? It is sural nerve biopsy. Sural nerve biopsy. What will sural nerve biopsy show? First of all, the myelinated fibers, particularly the large and medium sized, they will be reduced in number. Second, there will be hypertrophy and proliferation of Schwann cells around the nerve, and that will give an appearance what you call as onion peel appearance. They will give an onion peel appearance. And this pattern is called as interstitial. This pattern is called as interstitial hypertrophic neuropathy. Interstitial hypertrophic neuropathy. Remember that now the mutation analysis of from peripheral blood, the genetic diagnosis is also available, but this is how you make the diagnosis, and this is something you can add especially for INI super specialty exam. And finally, question number 15. NEET SS 24, a child with focal seizures, it's a NEET SS question, recall, undergoes neuroimaging. His CT revealed serpentine. Serpentine means like a snake. Serpentine calcification, zigzag kind of with vascular malformations in the brain. Serpentine calcification is the other name for tram track or railway track calcification. And vascular malformations in the brain are nothing but leptomeningeal angioma. Leptomeningeal angioma along with serpentine calcification. What are we thinking of? Yes, the diagnosis is Sturge-Weber syndrome. How do these serpentine calcifications look like? They look something like this. So tram track, railway track, serpentine calcification, ipsilateral leptomeningeal angioma, focal seizure, ipsilateral glaucoma, everything fitting into the diagnosis of Sturge-Weber syndrome. Topic we have already discussed in details and should not go wrong if it is asked again in the exam. Now question number 16. It is also a previous year question, NEET SS 24, and students said the options were very similar, but students said, sir, this imaging, there was a single lesion with a scolex visible, the so-called dot sign was visible in the photograph. So the child with recent afebrile focal seizure is there, you can see, and afebrile means it's not some acute infection which is causing it. And if you see here, you can see the typical scolex present inside this well circumscribed lesion. This is a patient with Neurocysticercosis. Neurocysticercosis, single lesion. Now these patients, obviously you need to give albendazole, which is the drug of choice, but albendazole, if you start, sometimes there is the dying parasite elicits a strong inflammation which can worsen the patient and can cause raised intracranial pressure. So first we start with the steroid, then we give albendazole for about 1 week to 10 days, and then even after the albendazole is over, for up to 2 weeks you will give steroid. And because focal seizures are persistent, many of these patients benefit by giving carbamazepine. Now carbamazepine usage is not universal, but again it's a practical point, and here in this question we have to look at what is the best option among the options given. The best option among the options given is B, where steroids are given followed by albendazole. The sequence is important, plus you will be giving carbamazepine for focal seizure. So focal seizures generally respond to carbamazepine or oxcarbazepine, although the other agents can also be used. So best answer among the option is B. Please go through the Neurocysticercosis guidelines from the regular videos. It's an important topic. Moving to question number 17. A neonate was found to have serum TSH value more than 100 international units per liter on day 4 of life. What is the next investigation to be performed? Now, many of you would have gone through the neonatology part. There I have taken a question on congenital hypothyroidism, and if the value is high, what are you supposed to do? But some of you requested me, sir, please tell about the role of radionuclide scan in case of newborns for congenital hypothyroidism, and that is why I added this paper here, this question here. So how you are going to approach the simplistic version of various protocols, I have made it into a flowchart. Have a look at this flowchart. Some of you might be knowing about this flowchart already. So you will, as a part of hypothyroid screen, you will perform the thyroid screen, TSH with or without T4, you know that TSH is the one that we check for. And if it is abnormal, here the TSH is more than 100 international units per liter. Generally, it is more than 100 milli international units per liter, but we are assuming that, you know, the examiner meant the same thing. So if it is abnormal, the second test to do is radionuclide thyroid scan. There are many types of protocols. Some people prefer doing ultrasound earlier, but according to most of the standard textbooks, we first do radionuclide thyroid scan. Now, when you do iodine 123 radionuclide scan, you will find there are three possibilities. First possibility, there is no uptake. If there is no uptake, now you will do ultrasound thyroid. And if ultrasound thyroid shows no absent thyroid gland, the cause of congenital hypothyroidism is likely thyroid agenesis. This chart is called as diagnostic algorithm. It is not a treatment related algorithm. This is a diagnostic algorithm. So first you will do thyroid screen, second you will do radionuclide scan, and then you will do ultrasound thyroid. The sequence examiner can ask you in the exam. Apart from that, if you do ultrasound thyroid there with a no uptake on thyroid scan and you find normal thyroid, it could be TSH receptor antibodies. Please, I'm putting a star here. It's an important fresh MCQ can be made on this. What about if there is ectopic uptake? That will show ectopic thyroid, which will be a type of thyroid dysgenesis, and increased uptake will show dyshormonogenesis like iodine deficiency. So this radionuclide scan is the test that you are supposed to do in such patients. Question number 18. In a newly diagnosed case of sick child with type 1 diabetes mellitus, insulin was given. Which of the following will increase? Do you know that such kind of questions are also asked in the exam? There are very easy questions also asked, but still people get them wrong. They try to overthink. How can the question be so simple? It's a common sense question. There is a sick child with type 1 diabetes mellitus. Is it possibly having type 1 DK, diabetic ketoacidosis? You know that sometimes diabetic ketoacidosis is the presentation of newly diagnosed diabetes mellitus, right? It can be hyperosmolar coma, but let's assume the common complication, diabetic ketoacidosis, is suspected. Now, when obviously you will not give insulin directly, first you'll go by the protocol, you'll make the diagnosis, you'll do ABC, airway breathing circulation, you will give fluids to the patient, and then you will start with insulin infusion. Once you start insulin, what is going to happen? Is the breathing rate going to increase? No, breathing rate is going to decrease. Already due to diabetic acidosis, there is respiratory center stimulation. So patient is coming with tachypnea. When you give insulin, what will happen? Insulin will reduce the breathing rate. So this will not be the answer. They are asking what will increase. Look at option number B. When you give insulin in diabetes, the blood glucose will come down and blood glucose filtration into urine will also come down. So glucose urea will decrease. So this cannot be the answer. Already in diabetic ketoacidosis, because there is glucose appearing in urine, so urine osmolarity is high. When you give insulin, osmolarity of urine is going to fall. It will decrease. So this also will not be the answer. What is the answer? C, pH. In diabetic ketoacidosis, the pH is low. pH is already low. If you give insulin and plus fluids, what will happen? The pH will improve. pH rises. That is, diabetic ketoacidosis resolves. This is what the question is asking. Sometimes questions like this make you question your existence. And even if you mark it correctly, you're in the game. But if you mark it wrong, suddenly you find yourself out in the cold. So easy questions also asked. Don't overthink. Try to see what examiner is asking and you will always get your answer correct. Question number 19. Now it's a spotter image. Identify the likely hormone deficiency. Here you can see a single upper central incisor. Single central incisor. Instead of two incisors, there is a single incisor. It is going in favor of growth hormone deficiency. Growth hormone deficiency, particularly in the young children and infants, it has a tendency to cause crowding of the teeth. Many times there can be a doll-like cherubic face along with single or overlapping or sometimes single, tooth will be there, incisor tooth will be there. Apart from that, these children can have risk of hypoglycemia and they can also have cleft lip and cleft palate. So these are the features which are fitting into it. It's a NEET super specialty previous year question. It is growth hormone deficiency. Question number 20. MEN1 syndrome is associated with which of the following condition? Remember, pheochromocytoma is a part of MEN2 syndrome and parotid and gonadal are not components. The answer to this question is D, pituitary adenoma. Similar question has been asked, not the same, but similar question has been asked in INI super specialty also. So what do you need to remember? You need to remember this table. The table says 3 types of MEN syndrome: MEN1, MEN2A, MEN2B. MEN2B is also known as MEN3. MEN4 is separate. MEN1 is due to MEN1 gene mutation on chromosome 11q, sporadic or autosomal dominant. All the 3 are sporadic or autosomal dominant. MEN2A is Rett gene and MEN2B is Rett gene on chromosome 10q. It is called as Wermer syndrome. This is called as Sippel syndrome, and MEN2B does not have a name. First is parathyroid adenoma, which is the most common manifestation, and it can cause primary hyperparathyroidism. There will be enteropancreatic tumors like gastrinoma, which will cause ZES, and there will be pituitary adenoma, particularly prolactinoma. You see, medullary carcinoma thyroid comes in both MEN2A and MEN2B. Here you will have pheochromocytoma also present both sides. The difference will be MEN2A will have parathyroid adenoma, which is not there on the other side. MEN2B or MEN3 will have marfanoid habitus, so long slender arms and legs and tall stature along with mucosal neuroma. So it's more of a mug up and answer kind of question, but still mugging up is also needed. Question number 21. Now this is a NEET super specialty 2024 MCQ. 10-day-old child presented with prolongation of neonatal jaundice, wide open posterior fontanelle. Now, prolongation of neonatal jaundice and wide open posterior fontanelle are features suggestive of congenital hypothyroidism. They are suggesting thyroid deficiency. Second, there is recurrent hypoglycemia. Recurrent hypoglycemia can occur in infections like sepsis. It can also occur in metabolic disorders, inborn error of metabolism. It can also occur in cortisol deficiency. And micropenis will indicate a likely hormone dishormonogenesis. Pituitary disorders can produce such a picture. Now, if you look at the overall picture, congenital hypothyroidism, can it occur due to decreased TSH production? Yes, it can. Can it occur due to, again, decreased pituitary hormones? Yes, it can. Cortisol deficiency, can it occur due to reduced ACTH? Yes, it can. So it is all fitting into a diagnosis of congenital hypopituitarism, and that is the answer. Look at the other options. Wolman syndrome does not present like this. It does not present in newborn, and the typical bilateral adrenal calcification is missing. Option number B, congenital adrenal hyperplasia can have hypoglycemia and micropenis, but it will not have prolongation of jaundice or posterior fontanelle. And thyroid dysgenesis will not have micropenis or hypoglycemia. It will have prolongation of jaundice and wide open posterior fontanelle. Thyroid dysgenesis typically produces the congenital hypothyroidism of the peripheral variety. Here we are dealing with a central type of hypoglycemia because there are associated abnormality, and so it is all fitting into a diagnosis of C, congenital hypopituitarism. Question number 22. Which of the following is not a component of Whittaker triad seen in autoimmune polyglandular syndrome type 1? Now, autoimmune polyglandular syndrome is also called as autoimmune polyendocrinopathy syndrome. It is of 2 types, type 1 and type 2. There are sub-varieties also described. Examiner can sometimes ask you to distinguish between them. And Whittaker's triad is described for APS type 1. In these patients, there will be Addison disease, that is adrenal insufficiency. There will be hypoparathyroidism, and there will be lifelong infection, recurrent infections with mucocutaneous candidiasis. So the odd one out, and the answer here is enteropathy. People sometimes get confused between APS type 1 and APS type 2. Important table. If you have not read it before, add to your notes. This is a very, very interesting, important table. So 2 types of APS. We are dealing with 2 types of APS. Type 1, type 2. Type 1 is autosomal recessive, type 2 is polygenic. Type 1 will have AIRE, that is autoimmune regulator gene mutation present on chromosome 21. Type 2 will have association because it is polygenic, so HLA DR3, D3 and DR4 linkage will be there. Addison disease is present in both the varieties, so adrenal insufficiency will be a feature of both varieties. Type 1 will have hypoparathyroidism and chronic mucocutaneous candidiasis, and these three are what you call as the Whittaker's triad. Whittaker triad does not occur in type 2, it occurs in type 1. Type 2 variety will have Addison disease along with type 1 diabetes mellitus, and it will have autoimmune thyroid disease. It can be either Hashimoto's thyroiditis or it can be Graves' disease. Question number 23. Upon presentation to the emergency department, a 7-year-old girl is found to have a serum glucose concentration of 700 mg per deciliter. pH is low, bicarbonate is low, and hyperkalemia is there. Don't you think this is fitting into diabetic ketoacidosis? And I told you, in any suspected diabetic ketoacidosis, first you start with fluids, because there is always dehydration, cellular dehydration, even if the patient may not have shock, and you always go with normal saline, not ringer lactate. Amount of fluid and the dose of fluid depends upon the degree of diabetic ketoacidosis. This is something I have discussed in good details in the protocols, in the updates on the Nelson as well as the PICU protocols. Please go through it. I have discussed in full details in 2-part video. Very important diabetic ketoacidosis. Last week again you have to go through diabetic ketoacidosis close to the exam. So first you start with fluid. In the first hour. First hour, you will be starting with fluids. Then you will be starting with insulin infusion. Never give insulin as bolus. Always start insulin infusion. It is given intravenously. The rate is 0.05 to 0.1 unit per kg per hour. And again, old MCQ, NEET as well as NEET SS. If you give insulin bolus, or if you start insulin before fluids, what will happen? That will lead to the development of cerebral edema in the patient. And cerebral edema is considered the most common cause of death in diabetic ketoacidosis. So what will you give in this patient? What is the first step in treatment? Obviously, you will administer a normal saline bolus. Now, the bolus, we call it as a bolus, but many times if you feel that the patient is not having very severe, low BP, you can give a slow bolus also to the patient over a period of about 20 to 30 minutes. You have to look at the options given here, and among the options, the best answer is giving fluids, that is normal saline. Question number 24. A patient with Ullrich-Turner syndrome. Do you know Ullrich-Turner syndrome is nothing but Turner syndrome? This is how you make out if someone is reading Turner syndrome from Nelson or not. It is mentioned in Nelson. Americans call it as Turner. We have also read as Turner. But Europeans call it as Ullrich-Turner syndrome. It's the same entity. Turner syndrome or Ullrich-Turner syndrome is having streak gonads. We know it. It's 45XO, monosomy X. But some varieties can have mosaicism. Mosaicism is 2 germ lines. And many times mosaicism can have a abnormal Y chromosome. It is seen in about 5% or less. If there is Y chromosome in Turner syndrome, there is a high risk of developing gonadoblastoma, and so you need to do prophylactic gonadectomy. This is a topic I have discussed. This is a point I have discussed in my detailed video. So do prophylactic gonadectomy. Do you need to do gonadectomy in every Turner? The answer is no. Which Turner would you do? Mosaics with Y chromosome. Okay. What about this germ cell tumor of mediastinum and carcinoma breast? They are both common in Klinefelter syndrome. Klinefelter, that is 47XXY. What about hepatocellular carcinoma? Long list, but hepatocellular carcinoma typically occurs in tyrosinemia. It occurs in GSD type 1, that is von Gierke's disease. It tends to occur with aflatoxin poisoning, etc. Remember that these patients can have hepatoblastoma also, but hepatocellular carcinoma has also been described, and obviously it will occur in chronic hepatitis B virus as well as chronic hepatitis C virus. Okay. Now, question number 25. Which of the following is not correct about carcinoid tumors? Now, carcinoid tumors or carcinoid tumors sometimes tend to produce vasoactive substances like 5-hydroxytryptamine. These 5-hydroxytryptamine will do multiple things. It will cause flushing. It will cause asthma-like features. It will lead to increased levels of urinary 5-HIAA secretion. In fact, 24-hour secretion of this can be used as an investigation of choice or a screening test also. Also in 5-HT patients, there will be carcinoid heart disease. We call it as carcinoid heart disease, which can develop. and these patients will have fibrosis of right side of walls, and patient can develop tricuspid regurgitation. TR can also occur. So the odd one out here, common sense question, is urinary 5-HIAA. And remember that if carcinoid syndrome is caused by carcinoid tumors and you are doing surgery, manipulation of the tumor can precipitate very high BP. That is called as carcinoid crisis. So it's more of a question which is occasionally somewhere asked. So we are supposed to read. Rare things will also be asked sometimes in the exam. Now again, this question, the ideal answer question should have been which of the following is not correct about carcinoid syndrome. But this very similar recall I found in one of the resources. So when you have a resource like this or a topic like this, you cannot argue with the examiner that you should be using the word carcinoid syndrome rather than carcinoid tumor. But by looking at the question and the option, you can easily make out that this is carcinoid syndrome which is being talked about. And so the answer still among the options will be A, urinary 5-HIAA is normal. Don't fight with the examiner, you can't. This is a fellowship kind of question which was asked some years back. Variations of this are there in NEET PG exams also, if once upon a time you have gone through the Q banks. Question number 26. Identify the incorrect statement regarding complete androgen insensitivity syndrome, CAIS. Now CAIS belongs to the class of things known as 46XY-DSD. They are genotypically males, so this is true. External genitalia is like female. There is complete insensitivity to androgen. So obviously the baby will develop like a female. So external genitalia is like female. Although the vagina ends in a pouch and the uterus is absent. Normal breast development occurs at puberty. True. The androgens themselves get converted into estrogenic compounds, and that leads to normal breast development even if menses do not happen. And testes are devoid of seminiferous tubules. False. Testes are present. Seminiferous tubule is present. It is just that the receptors, the tissues are insensitive, and that is why the answer to this question is D. Let's do a quick review. Complete androgen insensitivity syndrome, CAIS. Androgen insensitivity syndromes are the most common type of male disorders of sexual development. Inheritance, X-linked recessive. This is INI super specialty MCQ. This is INI SS MCQ. One-liner question was asked. Genotype is 46XY, but external genitalia is female. They are actually reared as female only. Vagina ends in a blind pouch, but uterus is absent. Testes are intra-abdominal and inguinal also. And if there is an inguinal mass, this can raise the suspicion it is a tumor-like lesion or a benign, soft lesion, which actually is testis. And when you do ultrasound, when you evaluate them, they will contain seminiferous tubules. At puberty, breasts normally develop, but menarche does not occur. The sexual hair is generally absent, and they develop the feminine characteristics, plus they are slightly taller compared to the normal females as well. But the menses will not happen, and that is a clue. And monitor for testicular cancer. Earlier what we used to do was we would remove them in the childhood. But then because it is removed, now already androgen insensitivity is there. Now you have removed the testes because there is a risk of cancer developing. So now what is happening is the testosterone is not getting produced at puberty. This testosterone which gets produced at puberty is the source of estrogen also. And that is what is causing, the pubertal development. So now what we do is we monitor closely, but do not remove it till about 16 to 17 years. Only after the puberty is getting completed, you will remove the testes in the patient. So remove them post-puberty. After in adulthood, you will remove them. And most common tumors, if they ask you in the testis which they develop, that is seminomas. Seminomas are the common tumors. And osteopenia occurs in most patients and is a cause of decreased bone density even in mid-adulthood period. Treatment, however, needs to be individualized. It is again, no two patients are same. It also depends upon at what time the patient has been diagnosed. There is also a role of psychological counseling in the patient. Imagine a girl who has been like a girl. And the parents think she's a girl, and only when she reaches her puberty, you realize she's not a girl, she's a man. And we are not talking about gender dysphoria or, the subjective perception of the person. Here we are talking about an actual underlying disease. The actual underlying disease is androgen insensitivity. So again, no examiner will ever ask you what is the treatment. Treatment needs to be individualized. You can read Nelson for more details on this. Right. Question number 27. Strongest association of type 1 diabetes mellitus is associated with which viral infection? The strongest evidence, Nelson clearly says, it is with rubella. If you look at the literature, all 4 of them, especially the first 3, have been found to be associated. Strongest is with rubella. What does Nelson say? Nelson says the clearest evidence for a viral infection is seen in congenital rubella syndrome. Prenatal infection, if it happens, congenital rubella syndrome, 70% cases have beta cell autoimmunity and 40% tend to develop type 1 diabetes mellitus. Sometimes the gap between the infection and the onset of type 1 diabetes can be as long as 20 years. For the others, the evidence is not as strong and it is generally lacking. So answer to this question is B, that is rubella. Question number 28. A patient with endocrine abnormality detected to have TBX1 gene mutation. TBX1 gene mutation produces Dye-George syndrome, also called as velocardiofacial syndrome. This is a microdeletion syndrome, 22q11.2. This is where this gene is present. And these patients will have hypoplasia of 3rd and 4th pharyngeal pouches. Thymus does not form, parathyroid does not form. No parathyroid, what happens? Hypocalcemia happens in the patient. And this is what Nelson also says. TBX1 gene mutation, 90% patients Dye-George syndrome. And these patients, neonatal hypocalcemia occurs in 60% of the affected patients. Question number 29. In an 8-year-old child recently diagnosed with type 1 diabetes, when should you do the first evaluation for diabetic retinopathy? It should be done between 3 to 5 years. And among the option given, B is your correct answer. This is a very important table. Often asked in NEET SS and NISS. So people who were asking me, sir, what tables are important? This is another table from Nelson. So this is talking about the time of, monitoring and what should be the frequency and what you should be monitoring in a type 1 diabetes mellitus patient who is a pediatric patient. So thyroid disease, you check for thyroid disease in type 1 diabetes at the time of diagnosis, then every 1 to 2 years or any time if symptoms appear, and you will be checking for TSH and thyroid antibodies because it's a autoimmune, likely to be autoimmune. Celiac disease at diagnosis within 2 years and again at 5 years or sooner if symptoms appear. Obviously, you will do total IgA and IgA TTG variety. Hypertension at diagnosis, and you have to check BP at every visit, and you will say elevated BP if it is above 90th percentile for age, sex and height on 3 separate occasions. Okay. Then dyslipidemia, you will be checking at or beyond 10 years of age. Nephropathy, you will be checking at puberty or 10 years of age, whichever comes first if type 1 diabetes has been there for 5 years or longer. Retinopathy, you will check between 3 to 5 years when age is more than 10 years. Or puberty, whichever comes first. Now, with this in mind, go back and see the question. What is the question asking? It was not as easy question. 8-year-old child, he has been diagnosed with type 1 diabetes. First evaluation should be done. It should be done at or beyond 10 years of age. Now, many people would be marking C as the answer. They are not saying 10 years of age. They will be saying after 3 years. So 8 plus 3 will be 11 years, and this is the time you should be doing retinopathy screening. Look at the table again. Table is saying retinopathy, you will do evaluation if type 1 diabetes has been there for 3 to 5 years when equal to or more than 10 years or puberty, whichever comes first. So you will not be waiting. See, if you, in this patient, if you do after 10 years, it will be 18 years. It will be too late. So what is the best answer? The best answer in these patients will be after 3 years. It will be the peripubertal age group when you will be doing. And annually you need to do. For nephropathy, you will be checking for albuminuria and urine albumin to creatinine ratio. Here you will be doing a dilated eye examination. Neuropathy, you will be doing at puberty or equal to more than 10 years, whichever comes first, if the type 1 diabetes has been there for more than 5 years. And annually, you need to do it, repeat it, and foot examination is needed for checking for neuropathy. This is, let me tell you, it is a difficult table to remember. You need to understand, read it slowly, and then add to the notes. But it is a table which might give you an MCQ in the future exam. So read this table closely, read Nelson, and go back and see the question again. It was actually a tough question. It was masquerading as an easy one. It was a tough question. Finally, we come to question number 30, CAH topic, CAH question. 4-week-old male child found to have hypoglycemia, hyperpigmented scrotum, hyponatremia, hyperkalemia, BP below 3rd centile. We are dealing with salt wasting kind of presentation. Salt wasting means there is no hypertension, So 11 and 17 cannot be the answer. We have already discussed it. Baby also has micropenis with bifid scrotum and undescended testes. So this is a male child with ambiguous genitalia. Male with ambiguous genitalia, it cannot be 21 hydroxylase. It generally has normal genitalia in male. Ambiguous occurs in female. So what is the likely diagnosis? The odd one out, and the answer here is 3-beta hydroxysteroid dehydrogenase deficiency. Remember the funda whenever you have a CH patient. Exceptions will be there, but always look at the type of crisis. If it is salt wasting crisis, where there is low BP and hyponatremia, you will think of 21 hydroxylase and 3-beta hydroxysteroid dehydrogenase deficiency. Whereas if it is salt retaining variety, where hypertension is there, you will be thinking of 11 beta and 17 alpha. Out of them, 11 beta is more common, 21 H is more common if you have to choose. Then after this step, you will be looking at genitalia. Remember that 21 hydroxylase as well as 11 beta hydroxylase deficiency, they cause normal genitalia in males, but they tend to produce virilization, that is ambiguous genitalia, in females. About 17 alpha hydroxylase deficiency, generally it produces normal genitalia in case of females, but produces ambiguous genitalia in case of males. And 3-beta hydroxysteroid dehydrogenase deficiency generally produces ambiguous genitalia. There are exceptions to this rule, let me tell you. You need to go through the detailed video, but this will make sure that the simpler questions which are asked in the exam will not go wrong. Now, if you look at the question again, the answer is very clear. It is D, 3-beta hydroxysteroid dehydrogenase deficiency. So I hope you benefit from this discussion, and take care, keep learning, and more such sessions will come your way shortly. Thank you.